Welcome. I'm Dr. Stacey Rosen, volunteer president of the American Heart Association for 2025-2026.
Hi, and I'm Dhruv Kazi. I'm the chair of the writing group for the AHA Presidential Advisory on Healthcare Affordability, From Crisis to Action.
So we all know that we're in a crisis with healthcare affordability. At present, we're spending over $5 trillion on healthcare expenses, with predictions having healthcare expenses consume 20% of GDP by 2033. We also know that cardiovascular diseases and other chronic conditions cost a disproportionate amount of funds toward this total income, and that we know over the next 30 years that it's expected to quadruple. Cardiovascular diseases spending, both direct and indirect, will quadruple by 2050. But we wanted this advisory to be more than just a restatement of the current status. We know this, but we know that something needs to be done. Inequities are becoming more notable and more important, and we know that no one solution, no one group can fix this. So Kazi, tell me a little bit more about the approach taken to developing this advisory, please.
Thank you, Stacey. What makes me excited about this particular advisory is that we went beyond describing the problem from a theoretical framework. We set up, as you know, listening groups across all stakeholders. So we involve patients, health systems, providers, payers across the board to try and understand the problem from their perspective. And the goal is to not just describe the problem, but rather describe the impact that it has on patients and all of the stakeholders, and then develop principles in which we can anchor solutions. And so what I'm really excited about is that this is a forward-looking statement focused on solutions rather than simply restating the problem.
That's fabulous. So the idea of authentically listening to different stakeholders, because it's clear that healthcare affordability is nuanced. It almost feels like that elephant, depending on what part of the elephant you're touching. Tell us a little bit about the drivers that the group found in creating this advisory. What are the main drivers to the different stakeholders regard to healthcare inaffordability?
Well, the common narrative we see is that healthcare is unaffordable because we in the United States use too much.
Yes.
And that is not true. That healthcare utilization is a very small part of our affordability problem. In fact, huge sections of the population are not even getting the care they need. And so they may be underutilizing care, particularly underutilizing high-value care. The major driver of our healthcare expenditure is the fact that we pay too much for individual services or products that we use. So whether it's drugs or devices, our prices are higher than in our peer countries. Our labor costs are rising. And so it's the cost per service used that is very high, and it's driving up healthcare spending. Of course, this is all happening in the context of we're an aging population. We live in a fragmented health system with very high administrative costs, and we've underinvested historically, both in public health and in primary care. And all of that is problematic at this point when we try and control healthcare spending.
Absolutely. And let's speak a bit about, if you would, about growing inequity. We know that a mission of the American Heart Association has always been improving health outcomes for everyone, everywhere. What did the group find in creating this advisory with regard to the importance and the impact of inequities in healthcare access, delivery, and outcomes?
That's a really important question that the group tried to address. Of course, the main burden of healthcare inaffordability or healthcare expenses is borne by our patients. And that shows up in the form of being unable to afford care that they need, or when they use the care they need, they end up in medical debt. We are unique among high-income countries as having a population with substantial amounts of medical debt. 22 million Americans are carrying medical debt, adding up to $220 billion. It's the leading cause of bankruptcy in the US. But it's not just patients. Healthcare systems are under strain as labor costs are rising, and they are required to provide care even for individuals who are uninsured. Our payers are struggling to figure out how to make products that make sense for both employers and employees. We don't always think about this, but from an employer perspective, it really reduces competitiveness, because so much of the cost of making a car in the United States today is the cost of healthcare insurance. finally, of course, even though we pride ourselves in being a private insurance system, about half the healthcare costs are borne by public payers. And what that means is that in a debt-funded economy like ours, we're essentially kicking the can down the road. A lot of these costs are going to be borne by future generations. So we think it's really important that stakeholders come together now to find solutions to this problem.
I think that is one of the most intriguing and unique aspects of the advisory, that these listening tours were then incorporated into the advisory with actual quotations. And it was really fascinating because each of us comes to this challenge from a unique lens.
Absolutely.
Each of us may be a clinician and a patient and involved administratively. So seeing these quotes really allowed you to see the challenges, the frustration of each stakeholder's view of where they are trying to do right and where the challenges become because of this very complicated overlapping system.
Yeah, absolutely. And again, the listening groups are a prime example where that narrative that we are an expensive health system because we use too much care falls apart. You can hear this from the patients that they're not even getting the care they need.
Right. And then we don't even touch in those comments on what we define as high value care.
Yeah.
Often prevention is not an option for everyone optimally as we would like. Should we turn now to the principles of the paper?
Yeah, that's to me the most exciting part of the paper, in part because they're guiding principles that I am convinced that will stand the test of time.
Absolutely.
They are very aligned with what the American Heart Association has always believed in, and they go beyond describing the problem to describing solutions.
And that's the excitement, I think, about this not being necessarily a set of objectives, but more principles that will be sustainable, because this will not be easy to do. You see how the challenges and the costs, the expenses, the poor outcomes impact each of the different stakeholders. So I love the principles idea.
Yeah, and we also didn't want to presume that we know all the solutions, because something we learned from the listening groups, as you pointed out, is that this is an enormously complex problem where everybody brings their own perspective to it. But there are core principles we can all agree on. And key among them are the ideas that every individual living in the United States should have access to healthcare that is high quality and does not generate financial hardship. And that in particular, when we think that this is healthcare that is high value, cost effective, this should be made available to patients without substantial cost sharing. So either no co-payments or minimal co-payments. Now, we didn't approach this with rose-tinted glasses. We wanted this to be practical. And what we learned from our listening sessions is that this is not going to be easy, but more importantly, rather than framing it as an us versus them debate, patients versus payers, payers versus hospitals, we think that the only way to make progress on this is if all stakeholders come together and have an honest conversation about what solutions are feasible. And it's going to take some give and take across the stakeholders. If everybody is thinking about their own advantage, we're not going to make progress. This is what got us into this problem in the first place. We did point out that this is going to require substantial investments. So even though we're saying healthcare costs are high and we need to bring them down, there is the need for additional investments, particularly in people, infrastructure, and data. I mean, as a clinician, we see this every day that our clinicians, colleagues are working around the clock. This is as the system is clearly under strain. So you can't just take money out of the system. You've got to make these investments, including in infrastructure that is resilient to climate change shocks, other shocks coming down the pike, and data, because in this world where we're going to have a lot of solutions that are likely AI powered, having access to high quality data is going to be really important.
It's interesting because the approach really focuses on all of us in this together. I think it'll allow us as an organization, as a healthcare community, to iterate around things that work. We'll learn from each other, honestly, and that's why I think the principle approach is so beautiful. Let's talk about public health, which I think was the fourth of the principles, and investing in public health.
Yeah, I mean, one of the challenges with our fragmented health system, as you know, is that there are not clear incentives to invest in public health at a from a payer perspective, and clearly as a country, we've invested in public health. And so one of the things we call for is this recognition that not all of these additional investments should go into providing care when people are unwell, but a substantial portion of the investment should also be focused on keeping people healthy, keeping people well in their homes across the lifespan, including as the population ages.
Sure. We learned from the recent statistics update that few Americans have optimal cardiovascular health. And in moving toward a community, a U.S. population that becomes more cardiovascularly healthy, according to the Life's Essential Eights, we could save millions of events every year. And we know that that translates to funds for other important uses.
Yeah, exactly. I mean, and again, the goal of healthcare is not always to generate savings, right? Like the goal of healthcare is to produce better health.
Outcomes.
And we can't get there unless we think of both clinical medicine as well as preventative care. And it's been a priority for the AHA as we think about population health more broadly, population health for our most underserved communities, including rural populations, historically marginalized communities. And we want all of those voices at the table as we think collaboratively and creatively about solutions. This is going to take our best minds working together to find solutions to what is a pressing but complex problem.
Yes, absolutely. And the way this has been established and produced, it really, the collaboration of all those who will be impacted on altering, evolving the system is clear. That gets everyone together because each group, and as you see reading through the quotes for where the pressure points are, what the challenges are to improving their point of view, it's clear that no section, no stakeholder can do this alone. And that really forces the issue of collaboration, piloting opportunities together, and really testing new solutions to better outcomes.
Well, I'm really excited that this publication is out, and I would encourage everybody to take a look at the Presidential Advisory. Again, it's the Presidential Advisory on Healthcare Affordability from Crisis to Action. We've focused on listening to key stakeholders. There's beautiful quotes in there, and really put all our energy into finding guiding principles, and we hope you will enjoy them.
I too encourage everyone to read this important advisory. It truly reflects the work of the American Heart Association, going back to our core mission to be a relentless force for a world of longer, healthier lives.